Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
That's us.
I'm Justin Burke, joined tonight, as always, by Dr. Chris the True Man Chu and our producer, Dr. Brian Ward. Not quite yet, technically, but by the time this airs, Dr. Brian Ward, how does it feel?
Ooh, it feels weird. I don't know if I like it yet, but I'm here.
You're here. We love it. We're excited to have you on the team. You put together a wonderful episode for us. Our guest tonight is Dr. Peter Liu to discuss constipation, a great core pediatric topic. But before we get into the content, hey, Chris, can you tell us about the show?
Yeah, we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Peter Liu. Dr. Liu is a pediatric gastroenterologist at Nationwide Children's Hospital and an associate professor of pediatrics at the Ohio State University College of Medicine in Columbus, Ohio. He specializes in neurogastroenterology and motility disorders. As research director of the GI Motility Center, he conducts research evaluating novel, technology-based diagnostic tests and treatments for children with these disorders. He's also the co-creator and host of the NASPGHAN Bowel Sounds podcast. It's a pediatric GI podcast. Today, he teaches us how functional constipation is not really a diagnosis of exclusion, the core treatment of acute and chronic constipation, and when you're grasping at straws, you can consider ordering colonic manometry.
Ooh, yeah, we went deep on this one and got a lot of great pearls. He also shared a great NASPGHAN resource, a website, toolbots.naspghan.org. That's toolbots.naspghan.org, which, if nothing else from this episode, you should go check out right now. A really wonderful resource.
I can't hold it in any longer. People are going to be so excited at the final release of this episode. Just completely cathartic.
A lot of good constipation puns. We probably should have done more. All right.
They just wouldn't come out.
Yeah. Hello, Dr. Peter Liu. Welcome to the show. Welcome to the Cribsiders. We're excited to have you. Welcome to the podcast.
Thank you so much. It's an honor to be here. A longtime fan, so thank you so much.
We are happy to have another podcast expert coming from Bowel Sounds, the pediatric GI podcast. So this is almost like a collaborative episode. We are excited to learn more about you and about constipation. But before we get started, I first want to ask permission. Is it okay if we call you by your first name, Peter?
Of course, yes.
We're an informal group. We try to be informal with everyone. We always want to do it with permission, though. And I would love to get to know you better. I think Chris would love to get to know you better. Can you tell us a little bit about yourself, maybe in a one-liner, and tell us something about one of your interests outside of medicine?
Sure. So I thought a lot about this. I ended up going just with my Twitter bio, essentially. So I'm a pediatric gastroenterologist and GI motility specialist. Co-creator and host of the Bowel Sounds podcast. I'm a part-time DJ, husband, and relatively new dad. So I guess 15 months ago I became a dad, so it's not that new anymore. But
ooh, congratulations.
That's very exciting, although I do have to go back and follow up on the DJ question. What are you doing bar mitzvahs? What's the DJ scene like in Ohio?
So to be honest, I used to DJ weddings. I kind of stopped doing that. It's like too much pressure.
It's a lot.
It's a lot of pressure with like name pronunciation, and it's just too much pressure. So now I primarily DJ, to be honest, like hospital events. So
right on.
A couple of weeks ago was our Nationwide Children's Hospital like house staff graduation. So the first in-person one we've done since the pandemic. A few hospital events a year, some house party stuff, but
that's
not too much,
gig.
to be honest.
That's cool.
Pandemic hurt my business quite a bit.
It's still much cooler than any other side gig that I have.
So you have a 15-month-old, right? What is your favorite book to read to your 15-month-old?
Ooh, okay. Oh my God, I'm blanking on the name. It's I can picture it in my head. Okay, I'll choose a different one. So currently, the one that she loves the most is it's not good that I'm blanking on all the book names, but
You could probably
there's
recite
one
it
of,
from
like-
memory though. Everything else. And
It's more pictures. Well, yeah, what's the plot? Give us what's the synopsis? Yeah.
She loves this book about like women heroes in history. It's called like Little Women Heroes or something like that. But
I've seen that. I know exactly what you're talking about.
Yeah.
I don't know. Yeah.
You know, it's like Rosa Parks, Florence Nightingale, that kind of stuff. She
Good
loves
night
that book.
stories. Good night stories for rebel girls.
Something. Oh, I don't know.
Maybe no.
Something like that.
Little dreamers.
As you can
visionary
tell,
women
most of
around the world.
The reading is kind of cursory. We're just kind of flipping through.
right.
She doesn't know what it is.
It's also a great book.
Fun fact: if you Google "women heroes in history" children's book, there's a good list of options. So
We will put them all in the show notes.
we'll put them all in the show notes.
Do it.
Brian, you have a question?
Sure. This is an oldie but a goodie. What is your favorite advice for incoming interns as we come up on the start of intern year?
Ooh. So, okay. You know, I feel like one thing, I think there's a couple of things that I remember hearing myself that I feel like was really helpful, even though it wasn't like the usual, you know, follow your passion or, you know, that kind of stuff. They're both from my current mentor, who's now my chief, Carlo Di Lorenzo. One is punctuality is the politeness of kings. So just be on time. I feel like as an intern, for sure, you want to be on time for, you know, sign out and stuff like that, meeting with potential mentors, etc. It just goes so far, you know? And the other thing is that it's really not about finding your passion. It's about developing your passion, right? So if you go into it, you're not looking for something that you fall in love with at first sight. It's really more, I think for most experts, at least in my field that I've encountered, you know, it's really about something that they developed to become their passion. So I think it's like being open to working with different people. I think really kind of the mentor and the opportunity is more important than maybe the specific disease process. So yeah, there you go.
Love that.
Yeah, that's great.
Love it. Great advice for incoming interns. Perfect timing. And now let's get into even more advice on how to take care of people that have trouble pooping. Brian, hit us off, man. Why don't you give us a start with
Brian can't even hold it in. He's got to bring it out.
All right. Well, we'll start with a case from Castle. I'm just going to ignore Chris. We're going to start with a case from Castle. A 4-year-old named Bristol. It's just Bristol.
You're the one who wrote the script. You can't
When I
remember
read
the
it,
name.
I was like, I don't get the, but now I get it. All right.
It's really bad and it gets worse.
Bristol.
So Bree comes into your primary care clinic for a well child visit. During the visit, her parent mentions that Bree only goes number 2 a few times a week and has some pain with straining. So why don't we start this whole discussion with a definition of constipation and what's really important in your mind when you're talking about or when you're diagnosing constipation?
Sure. Yeah. So of course, like no definition is perfect, but the one that I think is most commonly used, at least in the pediatric GI world, is the Rome 4 criteria, which are a set of diagnostic criteria that really apply to all kind of what were formerly known as functional GI disorders, now disorders of gut-brain interaction. And the pediatric criteria for constipation, for functional constipation, are less than 2 or equal to 2 bowel movements per week, greater than or equal to 1 episode of fecal incontinence per week, which we'll talk about more later, is a big difference from like the adult criteria. Stool withholding, painful or hard bowel movements, large caliber stools, or a large amount of stool in the rectum, either based on like digital rectal exam or potentially abdominal x-ray. And then so Brian, you mentioned like, or you asked, you know, what's the most important one of those? In reality, I think fecal incontinence is the most important thing to pay attention to, because as you guys all know, like or you might imagine or have personal experience, you know, that can be super devastating, you know, to anyone, especially a child's self-esteem. So I think that is it's like a huge red flag. You know, really that's something like GI bleeds, foreign bodies, button batteries are emergencies. To me, like fecal incontinence is like just a little below that. I just feel like that's something that can really be devastating. No one wants to talk about it. Can really drive a lot of like, you know, withdrawing from social activities. So to me, fecal incontinence is the one that matters the most out of those.
My question is about the Bristol stool chart. I can
Yes.
never, like, I don't have this thing memorized. I always have to look it up. Is there a better, is it useful first off? And if it is, like, is there a better way to remember this? Or do I just always have to have this thing in my Photos app on my phone and just,
Right.
you know.
So, okay, I will say there may be a few things that I say during this interview that I feel like I might get, some hate for. I personally don't use the Bristol Stool Scale that much. I think it's helpful for research for sure. So a lot of our studies, we use it. We have like the picture right there. We ask people maybe on RedCap to like choose one. But in reality, especially for kids, I usually ask, hard stools, rocks, hard, that kind of stuff to like soft pieces, mushy, more general terms. I use a lot of food analogies like banana, mashed potatoes, that kind of stuff, applesauce. So no, I think you're fine in not using the Bristol Stool Scale on a regular basis.
And I was going to have a similar question, Chris. So I'm glad you mentioned that. And I feel like for some of the kiddos that are, 1 or 2 years old and younger, I have a lot of parents coming in that are worried about their kid really straining. And one of the things I usually try to, if there's not, encoparesis or there's not fecal leakage, I'll ask about like, is it raisin, or is it banana? That's not really aligning with the Rome 4, but how do you approach diagnosing constipation if you are in a 1 or 2 year old or younger?
Yeah. So I do think that it's, the criteria that I just mentioned, right, doesn't fully apply. Like certainly they can't have fecal incontinence, right, because they're in diapers. So a lot of it's going to be, so you mentioned straining. I do think that straining, pain with bowel movements is a big part of it. Although sometimes, especially in infants, they can have dyschezia where it can be difficult to coordinate the muscles to pass stool. They strain a lot, but the stools are still soft and regular. So I think it's a combination of straining, bowel movement frequency, stool consistency. It doesn't have to be necessarily like a certain level of like Bristol Stool Scale, but just hard consistency and dry, that kind of thing in general. So yeah, the criteria do have to be kind of adapted based on the age, developmental stage, that kind of thing.
And so what are some of the organic causes of constipation? What are some of the things that can cause constipation that we worry about? What's on the differential when an expert like you sees someone who is having constipation or trouble going to the bathroom?
Yeah. So, before I kind of mentioned the criteria for functional constipation. So just to clarify, so that's constipation that's not caused by an underlying disease. And so we, kind of call those causes, quote unquote, organic causes, although we're kind of moving away from that nomenclature also. But anyways, so yeah, there are some underlying diseases that we don't want to miss that can present as constipation. And the groups that I think about really depend on, in large part, age and age of onset, and also maybe also some like other parts of the story. So I think the first kind of broad category to think about are for the children who come in maybe like as an infant or a toddler where their constipation began really early on. So if the constipation began in like the first month of life, especially, we want to make sure we don't miss a congenital abnormality like Hirschsprung disease, for example, if maybe meconium passage was delayed after 48 hours or something, or anorectal malformations, spinal cord abnormalities, especially if there's other like neurological signs or urinary symptoms. For kids who come in with constipation and maybe also bloating, pain, poor weight gain or growth, especially poor weight gain or growth, we do oftentimes screen for things like celiac disease or hypothyroidism. For example, if rectal bleeding is part of the presentation, like sure, hard stool can cause an anal fissure or a small tear and some bleeding, but if it's more than just like really occasional, you want to make sure you're not dealing with things like perianal Crohn's disease. So I have a couple of Crohn's disease patients who really presented with constipation. So I think age makes a difference, but also some of those other things that we see that might be kind of like red flags that we're dealing with something more than just functional constipation.
Now, does functional constipation or DAGBA or DAGB, whatever we want to call it, does it need to be a diagnosis of exclusion? Because it sounds like there are so many other things that it can be. I would find it difficult to try to rule out all those things first. How do you go about that? And are there specific red flags when you're gathering history that will ping you to go one way or the other?
Yeah. So first of all, it is not a diagnosis of exclusion. And in reality, so you alluded to like the change in name from functional GI disorders to disorders of gut-brain interaction. And really for all those disorders, it is no longer a diagnosis of exclusion, right? So all those disorders, like for example, things like irritable bowel syndrome 2 decades ago, no one knew what caused that. Now we have so many known factors and mechanisms that cause that it's really not about making like a negative diagnosis. It's about making a positive diagnosis based on the criteria. So that's kind of the same thing for functional constipation, especially because functional constipation really makes up the vast majority, especially in pediatrics, of what causes constipation in children. So no, there's not like a diagnosis of exclusion. It's really more when the presentation or maybe even the response to treatment doesn't fit with functional constipation that we want to make sure we're not missing other things.
So this is great. So I'm hearing almost that like it's functional constipation until proven otherwise. Is that safe to say?
Yeah, I would say like if there are parts of the story or on the exam, which we'll talk about a little bit later too, that make you worry, then yes, further evaluation may be needed. But if it fits with the, like the diagnostic criteria, there's not those red flags, then you may not need any more testing.
Do we know more about physiology? Like what is the underlying mechanism here? It sounds like there's something to do with gut and the brain. And I know that serotonin's involved probably, that I've heard in the past. Like, can you explain that a little bit?
Yeah, sure. So one thing I will say, the whole term of disorders of gut-brain interaction, I feel like my opinion is that it fits a little bit better with certain kinds of disorders like irritable bowel syndrome or other abdominal pain disorders, where we know it's more nerve sensitivity, interpreting those signals, that kind of thing. Functional constipation, to make a distinction from those kinds of disorders, in younger children especially, the most common reason we see it is because a hard poop was painful and led to withholding. And then that withholding, whether voluntary or involuntary, has perpetuated the cycle of stool retention, drying it out, that kind of. So it's not really the same as like gut-brain interaction, although there's some of that, if like the body's telling the child they have to go and they're withholding, then yeah, there's some communication that's not necessarily going right. But yeah, that's kind of like really probably the most common mechanism, quote unquote, underlying constipation for children, especially for younger children. As we get into like the teenage years, it becomes a little bit more like adult constipation in that we can see things like pelvic floor dyssynergia or pelvic floor dysfunction leading to outlet problems, not being able to fully empty the colon. But yeah, especially for the younger kids, withholding and stool retention, building up, difficulty passing that, perpetuating the cycle is probably the most common underlying pathophysiology.
So as we talk about distinguishing these disorders of the gut-brain axis and other issues, who does get workup?
Yeah. So I think it goes back to those concerning signs that would make you worry about an underlying disorder. So for example, the child with really early onset constipation, it doesn't even necessarily mean like specialized testing. You just want to make sure you do a good exam, a digital rectal exam, especially for those who've had early onset constipation, to rule out like a positional problem or a structural problem, things like that. So I think it's if the onset concerns you, if there are other parts of the story like bleeding, poor growth, poor weight gain, those are the patients that should get evaluation. I would say that people do differ a little bit in like their threshold for getting, for example, celiac disease screening for an older child who's having constipation. But to me, I think it really makes the most sense for children who also have issues with weight or other kinds of supporting symptoms, or they're just really not responding to your usual treatment.
And one thing I know that Chris really likes to do if a pediatric patient's coming into the emergency department with abdominal pain and a history of not having pooped is he likes to order an abdominal X-ray just to
radiation
confirm
therapy. That's usually works, I hear.
To confirm constipation. What are your thoughts on Chris's practices?
Oh man. So yes, abdominal X-rays are a big source of consternation, stress for pediatric gastroenterologists everywhere. I think that in reality, of course, abdominal X-rays have their role, but I think there's a little bit of over-reliance on abdominal X-rays, especially when it comes to constipation. So certainly abdominal X-rays should not be used to diagnose constipation, right? Like constipation, the diagnosis is based on the story and the history. Everyone has some stool in their colon. Before you poop, there may be stool all throughout your colon. That's a totally normal thing. For all of us who do colonoscopies, I mean, it's shocking, even with people who do a prep, how much stool is in the colon. So certainly having stool in the colon does not mean you have constipation. It just means that, as one of my colleagues likes to say, you're a member of the human race. So not an abnormal finding. So it should not be used for diagnosis. Certainly, like there have been a lot of studies showing that so much variability in how people interpret stool volume in an X-ray. But that being said, we use abdominal X-rays too sometimes, right? So it's really more, it's not to make the diagnosis, but sometimes if you're able to demonstrate, for example, a tremendous amount of stool retention, that might affect how you like shape or how you do their clean out, for example. If you do an X-ray and they have a huge like rectal impaction, you might want to do rectal enemas or suppositories instead of just an oral regimen. If you're seeing a patient with fecal incontinence, you suspect constipation, but the story doesn't totally fit. If you get an X-ray, there's no stool, they're having like active fecal incontinence, then it does not sound like it's retentive fecal incontinence because of constipation. So there certainly are times when abdominal X-rays can be helpful, but I think everyone has seen or heard of a case where a kid came in with pain, an X-ray showed stool, got discharged with a clean out, and then they came back, the next day with something like appendicitis or something, So there's a lot of, I guess it's just people have to be careful about getting an X-ray, not relying on it too much, and not necessarily stopping the workup just because we see stool on the X-ray.
So what does more workup look like? Is it, I know you said a little bit something about celiac workup, but maybe for our older kids with maybe some weight or other type of changes in terms of growth, are there other labs we look at, other imaging, and what's more in the wheelhouse of like the primary pediatrician? And then we can talk a little bit about like further on after that.
Yeah, sure. So I think one point I want to drive home is that if the kid comes with constipation, that is like the typical story, no red flags, they don't need any testing, right? And so testing really should be reserved for those who don't respond or have other parts of the story that are a little bit concerning. I think like for the older child, lab evaluation wise, I'd say that the ones that we most commonly will order are going to be celiac disease screening and a thyroid panel. So celiac disease screening, so like an anti-tissue transaminase IgA and an IgA level. So celiac disease, especially in younger kids, obviously for older kids, we typically think more about diarrhea, bloating, pain, that kind of stuff. But for younger kids, sometimes constipation can be the only presenting factor. So those are the two things that we typically will screen for. But I really feel like if it sounds just like constipation, I would at least try treating it first. If it goes away, you may not need to do any more testing.
I love it. And I think this actually is a great segue into some further history that we get. Brian, do you want to tell us a little bit more about Bree?
So on further history, Bree's parent says she's had some trouble potty training, and she had some trouble potty training when she was younger. She spends most of her days inside doing arts and crafts, drinks a glass of milk every day at dinner, and her older siblings also have struggled with constipation in the past. So listening to the story and thinking more broadly, what are some risk factors for developing constipation?
Yeah, so going through little Bristol's history, just a few things. So first of all, definitely there can be certain times in life or like life stages where we typically will hear constipation began. And so you mentioned toilet training. So that's a very common age for constipation to at least start getting worse. Even before that, I think another example would be when babies are introduced solids. So that's another common time when stool form will change, and then maybe there's some discomfort, and then there's some withholding, and then we have like a toddler who's withholding every time they have to poop. I think going to school, moving, big life changes like that will oftentimes hear constipation beginning then. Obviously, we can't avoid those times, but anyways, just an observation. The next part, so Bree likes arts and crafts, so maybe doesn't like running around outside that much. In reality, there's not a lot of data about exercise, physical activity, and constipation in children. I think anecdotally, we do think that, if you're more active, that should help with constipation, but we don't prescribe like intense workout regimens for our patients with constipation. I think it's really more just encouraging being physically active, like for any child. You mentioned milk intake, so that's another kind of controversial topic that, I think especially, even in pediatric GI, there's some confusion about, really there's not good data that cutting down or eliminating milk helps with functional constipation. There have been a couple studies that showed some improvement in constipation with eliminating milk, but really those were small groups, younger children, potentially who also had some like allergic symptoms or milk allergy. So we don't ask families to restrict milk intake just for constipation alone. And then, go ahead.
No, I was just following up on the dietary question. Are there other things that seem to exacerbate constipation? And not to do the double-barreled shotgun question, which I am prone to do, unfortunately. But if someone is exclusively breastfed or exclusively formula fed, how does that factor into your decision? Is it possible that they're constipated when they really only have one dietary source?
Yeah, so I guess first about diet in general, there have been a lot of studies looking at increasing fiber intake, maybe beyond like our usual recommended fiber intake. And for kids, there has not been good data that improves constipation. So our constipation guidelines, which I can provide like the reference for later, they do talk about fiber, but really it's just about making sure that a child is getting adequate fiber, which in reality, may still be changed for most of the kids we see. But anyway, so adequate fiber, and same with hydration, so a lot of families are like, oh yeah, I tell her to drink water all day, but as you guys know, that just makes them pee a lot, not necessarily soften their stool. So we also just encourage like adequate hydration. Definitely there are some, especially fruits that can help soften stool. Prunes, apple, pears, commonly recommended. There's some studies actually that kiwis can help soften stool. But it's hard to have like an exclusively, high kiwi diet. But those are things that that I'll mention, especially for families that want to try more dietary approaches than rely on medications. As for like formula fed versus breastfed, at that, especially when they're exclusively formula fed or breastfed, so like early infancy, really constipation at all would raise some of that concern for other problems, right? So that would not be a common age to be seeing bad constipation. That being said, just one kind of random thought. So we can see constipation in that age group sometimes develop because of milk protein intolerance or food protein induced proctocolitis, or commonly called cow's milk protein allergy. So that can cause some proctocolitis and then pain with defecation, actually to constipation, even though typically we think about, maybe mucousy stools or specks of blood in the stool. So something to think about there. Definitely formula fed versus breastfed infants can have different stool patterns, but anytime it's hard stool, painful, that kind of stuff, it's still going to be, we got to make sure we're not dealing with anything else that would predispose them to constipation that early on.
One question I have about sort of supplementation, you said something about fiber. Like how do you dose fiber? What's a recommended amount of fiber? I think part of our pre-reading that we got this read this NAFGAN guideline from I think 2014, 2015, and actually it didn't even. I think in those guidelines they say there's not enough evidence to really show that fiber does much. But as you're thinking about, like, it's not like fiber can probably hurt you that much either, so it might be a reasonable treatment. I was just wondering, like, how do you make that discussion? Do you just give them a handout of high fiber foods, or do you say, hey, we can buy some Metamucil off the shelf, take a capful every day, 2 capsules every day? Like, how does that work? What does that sound like?
Yeah. So in reality, I don't often recommend fiber supplements. I feel like if they've reached me, I would like to try medication that we know is effective. That's going to be like more effective than just trying fiber. If families feel really strong about it, then yes, sometimes I will recommend over-the-counter supplements. But in reality, I don't give them strict guidelines. I feel like, the evidence pretty clearly shows that for treating constipation, medication, stool softeners, stimulant laxatives will be much more effective. So I try to focus more on that.
Can we now talk about those then? Like which stimulant laxatives are you go to? Which are the ones that people probably should stay away from? What are the pros and cons of each of, because there seem to be lots of options, everything from PEG to lactulose to, like, what do you reach for from your toolbox first? Yeah.
So it does depend a little bit on age. So I'd say that infants are a little bit of a different category, and then there's like older kids. So for infants, for example, in reality, for young infants, like we kind of talked about, like if they're developing constipation, we want to make sure we're not missing anything. I oftentimes will like verify formula mixing is correct. We might think about trying to eliminate milk, protein, soy, that kind of thing. Older infants, I typically start with a stool softener like lactulose, sometimes milk of magnesia. Older infants, I might start using PEG 3350 or Miralax. For older kids, I do start with a stool softener first if it hasn't been tried already, like PEG 3350. That's going to be, it's not necessarily more effective than other stool softeners, but in head-to-head studies against things like milk magnesia or mineral oil, it's definitely better tolerated and kids are more compliant with it. So that is still kind of like in the guidelines too, the go-to medication. But there are many choices for stool softeners and then a couple of choices for stimulant laxatives. So in terms of softening, so PEG 3350, lactulose, milk magnesia has some softening effect. Mineral oil, not super well tolerated by mouth, but sometimes kids do drink it. And then if a softener by itself is not enough, then I will add or substitute for a stimulant laxative. In kids, really the two that we use are going to be Senna and Bisacodyl. And, Bisacodyl comes as a tablet and it shouldn't be crushed. So really for younger kids, it's just Senna. So Senna, I feel like is pretty well tolerated. And I think it's one of those things that may be a little bit underused. For me, I feel very comfortable with using Senna or Bisacodyl. I think there's a lot of concern out there about making the colon lazy or dependent on the stimulant, but really there's no evidence for that, especially for kids. Like we use that a lot. And if anything, what makes the colon more quote unquote lazy or hypomodal is going to be if we don't adequately treat the constipation, there's retention, colon gets dilated. It's really going to cause the problem rather than a stimulant laxative. So to me, I have no problem using stimulant laxatives for kids as well. I think the goal is going to be, especially when they're withholding, how can we generate contraction strong enough to push past that to still empty the colon? And sometimes a stool softener by itself is not enough to do that. So that's where I begin, at least for oral medications.
And I'd love to follow up on that as far as if you have a patient that you've diagnosed constipation who's coming into your office, do you automatically kind of start them on maintenance therapy where you're giving them daily medicine? Or do you ever is there in your mind, is it acute treatment and then we'll see how it goes? What's your kind of approach is there a difference between acute treatment of constipation and chronic treatment of constipation?
Right. So the treatment does depend a lot on the history. I think one of the big first decision points is going to be whether or not they have some degree of stool retention that requires some degree of a clean out. For example, if they're having fecal incontinence, then that implies some degree of a fecal impaction. And so they would definitely require some degree of a clean out. So I think that's one of the first steps. So the acute treatment may be a little bit of a clean out, higher doses for a couple of days until there's a good amount of stool output. But I do feel like, especially for the patients that we see who've usually been struggling with this for several months or even years, I do think that maintenance treatment is a big part of really eventually moving on and no longer needing medications, which is obviously still ultimately the goal. So I try to impress upon families that, I don't want this, your child on medications either. I think the way to get there with having their constipation under control is regular use of medications now and finding what's going to help them empty their colon so they know it's easy to pass, they can relax, that kind of thing. So, so like acute treatment, maybe a clean out, but I do feel like maintenance treatment is important. It doesn't have to be super aggressive, but just enough to make sure that the child is consistently fully emptying their colon on a regular basis until their body can kind of get used to that and then maintain it without a medication.
And for a clean out, what is your typical, what's a genius like you doing for a clean out? Is it, when do you determine inpatient versus outpatient? Are you throwing an NG tube in the office, or is there a certain number of capfuls, or is it just drink until you fix it? What's your clean out regimen?
Yes. So I rely on the actual geniuses that came before me. So we do have kind of like set regimens that we use. And like I said before, it kind of depends on the presentation for sure. In reality, we'll oftentimes recommend the cleanouts that we recommend for our patients before a colonoscopy. For us here, it's really higher doses of PEG 3350 and also a stimulant. So based on age, whether it's Senna or Bisacodyl. Just to give like an example, so for our older kids, teenagers, we'll actually ask them to take up to 14 capfuls of Miralax mixed at 64 ounces over the course of half a day with Bisacodyl before and after. So that's kind of like our usual for teenagers, older kids, over 40 kilos, that kind of thing. And then it's kind of adjusted for younger children. So that's our typical like outpatient clean out. I had alluded to before, if we know that there's a lot of stool in the rectum, then we may want to introduce rectal enemas or suppositories as part of that clean out. So for sure, If you know all the stools at the bottom, giving tons of medications from above is going to be way less effective than giving a mineral oil enema or a stimulant like a bisacodyl enema directly to where it needs to go. As for when we admit kids to the hospital, so I definitely am not putting in NGs in clinic. Really it's going to be oral medications, potentially rectal medications if the child can tolerate it. For more severe patients, and what I mean by that is like if they've tried these outpatient cleanouts, but they're still not able to empty their colon, especially if they're still having a lot of leakage, fecal incontinence, bloating, pain, decreased appetite, those kinds of things where they're vomiting up the cleanout, they can't tolerate it. That's when I would think about bringing them into the hospital for a clean out. And as you alluded to, typically that looks like, really the first part is going to be rectal enemas, usually on a scheduled basis, trying to make at least something move. Like if there's a huge impaction, in many ways, it's a functional obstruction, right? So we don't want to just start pumping stuff in from above. We've run into some problems with that here, like in the past, especially for our developmentally delayed children or autistic children, where they can't really express some of that discomfort that can arise from stuff really, backing up and nothing moving forward. So anyway, we try to get stuff moving from below first. Usually that's enemas, mineral oil, saline, sometimes a stimulant. And then if that doesn't work, then we may have to do a manual disimpaction in the OR. And then after that, we place an NG and then typically go lightly, new lightly until stools are clear. We usually verify sometimes afterwards with an x-ray. But yeah, that's our typical kind of inpatient plan.
So this is interesting. So I was saying I was looking at the NAF scan guide, the NAF, NAF scan guidelines, NAFSPGAN guidelines from 2014, and they have these super intense algorithm. I mean, it looks like crazy man on the wall type workflows and it's like do they have constipation? Do they qualify? All right, then try treatment. They fail, then, and it's a treatment eval, like sort of big like thing. At what point as a primary pediatrician do I need to start freaking out and be like, maybe I need to get you to pediatric GI? Like what you're explaining to me, like probably when I know for a fact when I'm getting to like inpatient admission for some of these things, I'm probably going to have GI involved. What earlier area should I be doing this when I'm like thinking about doing these enemas? Should pediatricians be comfortable like prescribing these things while we're doing other workup?
Yeah. So I think that, the vast majority of kids with functional constipation will improve with really like fairly basic treatment. So educating the family on what exactly we're dealing with, for example, like making sure they don't punish the child for having an accident, that kind of thing. Some behavioral strategies, like maybe if it doesn't work for everybody, sometimes like, sitting on the toilet certain times of the day, that kind of thing. And then also, I do feel like every primary care doctor, provider should be comfortable with using stool softeners, super safe. I oftentimes have families adjust the dose even at home. And then ideally also one stimulant. I feel like that really is going to take care of most of the kids that we're seeing. And, but if we're still struggling despite that, then I think that's when it might be worth involving a pediatric GI. One thing would be to make sure that we're not missing anything else, but also maybe they would have some more comfort with using higher doses or some of our newer other medications we might use, or maybe they need some more testing looking more at the constipation itself.
Are there other newer medications did you mean?
Yeah, that was my question. What do you guys get?
Yeah, so I mean, there are a number of medications that are kind of more used in the adult world that we are starting to use more and more in pediatrics as well, especially for our older kids, teenagers. I would say that like this is probably not something the primary care doctor needs to like really know about, but just a couple examples. So for patients who have constipation or irritable bowel syndrome with constipation, we'll oftentimes use this class of medications called secretagogues. It includes things like linaclotide, lubiprostone. Those two we've been using more and more in children. Prucalopride is a pro-motility medication that we've been using really for upper GI and lower GI motility issues. But I'm a little bit biased as a motility specialist. I think most pediatric GIs are not using that a ton. But the thing is, unlike in adults, actually all three of those have had randomized controlled trials done in children, and all were negative. All of those were actually preceded by cohort studies that were positive, including ones that we've published. So there's that caveat. In reality, I mean, I personally feel like it's because the spectrum of what causes constipation in children is varied and can be very different for like a young child and a teenager. So I definitely feel like there are patients who really respond well to those kinds of medications. And in the adult world, those are used very widely. So yes, there are some newer medications that we're starting to use, but still softeners, stimulant laxatives should treat the majority of our kids with constipation effectively.
So from the new with mixed evidence to the old with mixed evidence, do you ever go to DocuSate? Is that ever something that you reach for?
No.
That was very definitive.
Yeah.
Shot down.
We'll cross that off.
Great. So we don't use it in adults and we don't do it in peds. So.
It has seen its day.
Yeah. I mean, yes, some pediatric GIs still prescribe it, but to me, the literature is pretty supportive of PEG 3350 as most effective and also most easy to comply with. So that really is kind of the mainstay for our treatment.
So sometimes treating constipation seems like it'll take a while, especially if we go through that entire workflow that I was looking at.
Yeah.
And so I could see parents freaking out, my kid only poops once a week. How worried should we be? Should we say, all right, at this point, it's been 2 weeks. We've only had 2 poops. We really need to bring you inpatient because of all the other red flags that we've talked about. Or it's we're still going every once in a while. Kid's not in that much pain. We're good. Or no, they just really have to go. Where on the spectrum should we be looking, and what type of complications can occur if we don't get these kids treated?
Yeah. Well, so first, to address this figure you keep on referencing, I think we in the GI motility field also agree that it's not the most helpful figure. It also kind of just leads to a point where once constipation is refractory to our usual treatment, it just lists all the possible options without any guidance. So yeah, so we also, in many of our talks, including my own, will make fun of that figure. But yes, okay, so your question, how do we decide how serious, how urgent this is? And right, so constipation, even though it's common, right? So, in population-based studies, about 12% of children will at any given time meet criteria for functional constipation. Even though it's common, it can at times be very serious. And, I'd say yes, the majority of children with constipation, the vast majority can be treated effectively as an outpatient and they never need inpatient treatment. Usually if we don't go for a few days, they'll respond to a change in dose of their stool softener, or maybe even an enema if they need it, that kind of thing. So no, I would not panic if they go several days without a bowelment. I think there's a lot of range that we can use those medications we talked about for. But definitely, in my opinion, if it's leading to fecal incontinence, if it's leading to significant impacts on quality of life, pain, if it's hard to tolerate the medications, that kind of thing, then yeah, I do think that's where we have to think about how can we get this under control. And sometimes that means trying some of those newer medications, doing some more specialized testing that we'll do to kind of look at what maybe the underlying mechanism is for that child with constipation, things like that. But yeah, the vast majority though will respond to the things that we talked about.
Can kids die from constipation that's untreated?
Yeah, so in reality, kids have died from constipation. It's not, obviously, it's extremely rare, fortunately, but we can see constipation over time get to the point where there's such severe stool retention in the colon. The colon is a very compliant organ. It'll keep on stretching to accommodate stool. Sometimes that stool can really build to the point where there is actually an obstruction, right? Just like any bowel obstruction. Sometimes that pressure on the bowel wall can lead to stercoral colitis and damage of the lining. And then ultimately perforations have occurred, even in our hospital. So yes, it is, I think, something that people sometimes underestimate how severe it can be, especially for certain populations of children. Like I mentioned before, our developmentally delayed children who may not respond to those cues as obviously. It may be harder to tell when they're in a lot of pain. In those kinds of patients, we want to really be careful that we don't run into those kinds of problems.
And so maybe to recap in my mind, if we have a kid who is presenting with persistent constipation, we've said, there's no clear findings of a spinal malformation or anal dysplasia. We're kind of not drawing any of those red flags. We can treat with PED, the polyethylene glycol, senna, and enema, and kind of continue to increase dose until we presume we will see some improvement. Are there specific dosings? I know you mentioned different on age, depends on severity. Is there a resource that you use or that I could use in a primary care setting that would kind of help guide whether I'm starting at 1 cap and how quickly to go up or to come up with a regimen?
Yes. So, we had alluded to before these guidelines. So NASPGHAN is like, I know it's like really hard to pronounce, but it stands for North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. That's our pediatric GI society. And those guidelines do actually have a table with dose ranges. And so I feel like I always tell all of our residents to like check it out. Even if you just Google like pediatric constipation guidelines, that should be one of the top hits. So yes, there's a table there for some dosing guidelines for not just polyethylene glycol, but some of the other options we have as well.
Beautiful. And then if we are treating with those higher doses and having some intractable constipation, it sounds like that's when we can really use some of our GI colleagues to kind of help explore and see if there are other causes. And you're right that in the graphic, it is somewhat comical of some of the other lists that are just treating accordingly. One pearl that someone taught me that I think is true, but would love to ask you to confirm is delayed presentation of Hirschsprung's disease. I feel like we always think you either have delayed meconium or not, but can you have a child or even adolescent presenting with Hirschsprung's disease, and what's that typically like?
Yes, so you definitely can. It's not very common, but yes, it is possible. So as you guys know, Hirschsprung disease, so ganglion cells, so not making it all the way down to the bottom, it can really be variable in presentation as well. Like the amount of colon affected can be the entire colon, or it can be a very short segment. So sometimes those kids with a shorter segment may make it to an older age without getting to that point where they get evaluated for it. So yes, we can see Hirschsprung disease in older kids. I'd say even just like a year or two ago, we had a 18, 19-year-old young adult who was diagnosed with Hirschsprung disease. And so it is something that should still be on the radar, especially if, long-standing constipation. So certainly if for an older child, the presentation usually is pretty dramatic in terms of like duration and then the amount of stool retention. But yes, it is something to like at least think about, especially, and maybe even act on if they're not responding to your like conventional treatment.
And as a pediatric GI doc, because I assume I'm not going to be ordering some of this stuff, but what does the workup, if you're worried about Hirschsprungs or some of these other things, look like? Like, I know there's things like rectal manometry or colonic manometry and rectal biopsies. I remember when I was a resident, like doing like a rectal biopsy just in clinic, like this little suction thing that's did a snap and stuff like that. Can you explain some of that and things that we might be seeing come back from our GI colleagues when we send our patients out?
Yeah, sure. So, right. So for Hirschsprung disease specifically, there's really kind of two main initial tests that we'll use. Actually, I would say actually three. I guess I'll start with kind of the most basic one would be a contrast enema, looking for a more narrow segment, kind of really distally, and then opening up into a bigger sigmoid, like a reversed rectosigmoid ratio. So the non-innervated part of the colon is going to be a little bit more contracted. So that's one screening test, but really kind of the more definitive ones would be rectal biopsy. So as you mentioned, that can be a rectal suction biopsy done with we have like a little rectal suction biopsy gun that we have. Or sometimes for our older patients, we'll have our colorectal surgeons do like a full thickness rectal biopsy in the OR. The other option would be an anorectal manometry study. So that's kind of like my specialty is like manometry testing, motility testing. For a kid that would look like, placing a thin, flexible catheter. It's like maybe the size of like an iPhone power cord. There's pressure sensors all along it, and then the nurse will insert it just a few centimeters into the rectum. So that measures anal sphincter pressure. The child can try to push it out. We can look at how coordinated the muscles are. And then for Hirschsprung disease in particular, there's a balloon at the end of the catheter that we gradually inflate to simulate a piece of poop. And then if the nerves are there and can tell and can sense it, there's a rectal anal inhibitory reflex where the nerves will tell the internal part of the anal sphincter to relax. So that reflex would then rule out Hirschsprung disease. So yes, there are several ways to look for that. And you also alluded to colonic manometry. So that's kind of a more intense test where we do a colonoscopy and drag in and place this like long manometry catheter. And then we leave it in for about a day or so, like maybe 6 hours, and see what the colon does over the course of the day. So that can help identify dismodal segments of colon. Like if you get an x-ray, there's a huge dilated sigmoid colon, are those contractions really there in that segment or not? Manometry can tell us that. Really though, in my opinion, colonic manometry is more reserved for when you're thinking about surgery. Like you've gotten to that point. Anorectal manometry though can be helpful much earlier on. Especially for teenagers, for example, if we're not really worried about Hirschsprungs, it can identify pelvic floor dysfunction where we try to push our anal sphincter, our pelvic floor is only tightening up instead of relaxing. Those kinds of things might be responsive to pelvic floor biofeedback therapy or physiotherapy that can kind of help guide treatment. And it's a minimally invasive, no anesthesia test. It's usually pretty well tolerated by kids over 4 or so years of age. So yeah, there's some tools that we can use to help kind of guide us where to go once we've kind of tried our usual treatment.
That's pretty great. And the colonic manometry it's not something I've typically done in primary care practice. And so it's good to have that exposure and know it's out there. I know that there's a wide variety of patients that present with significant constipation. One of the missions of our show is to really try to focus on health equity and how it affects different populations, whether it's based on race or socioeconomic status or gender. And I'm curious if there's data in constipation, and specifically also looking at, different levels of abilities and neurodivergent individuals, also a major part of diversity, equity, inclusion. Can you talk a little bit about maybe how neurodivergence can sometimes present with constipation, or if there's other concepts of health equity in this field?
Yeah. So I'll start by just saying, so yes, I do think a lot more work has to be done in that area in the world of functional constipation. This common problem that we know can lead to a lot of comorbidities and cost and that kind of thing. You mentioned like neurodivergent individuals. So definitely constipation can be more common and treatment may have to be tailored for that population. So we know, for example, for autism spectrum disorder, that's a very clear risk factor for having more difficult to control constipation. And, even just basic things like PEG 3350, we talked about it so much. And yes, it's supposed to dissolve. You're not supposed to taste it. But I feel like a lot of my autistic patients are like super tasters. They can definitely tell it's there. You may have to adjust. You may rely more on Senna, for example. Senna comes as chocolate squares. It can be a liquid. There's more flexibility there, that kind of thing. So there definitely are adjustments that have to be made. And I do think for autism in particular, there is a growing body of literature about how really a variety of GI diseases and disorders are different for that population and require maybe a little bit of a nuanced approach to their management. As for gender, so sex and gender can play a role in constipation. Like there's some data showing that maybe constipation is a bit more common in boys in the younger age group, which is a little bit different than in the older age group, but not like huge differences there. But certainly for race, ethnicity, there actually have been a lot of epidemiological studies in different countries all across the world. But, I think there's probably a lot more in terms of disparities, access to care, that kind of stuff. Just like for every other disease process that's been looked at, I'm sure constipation is no different. But really that aspect has not been looked at. So I think it definitely deserves more investigation.
Excellent. Thank you. Brian, maybe we'll do a speed round for the final case and then wrap up.
I love it. So for your final case, we're back in the clinic. Your last visit of the day is a young man named Holden Brown.
Yes.
He is a 15-year-old with autism spectrum disorder and long-standing constipation. He takes daily polyethylene glycol 3350. So I want to know, we've covered it a little bit. What does a typical maintenance regimen look like?
Sure. So yes, it does depend on age and severity, but for a teenager, I honestly would typically start with our usual standard dose, 1 capsule once a day. And we actually one of our GI fellows, Kate Hawa, recently created like a action plan for constipation that we studied and we're trying to get published. So because really these medications are safe enough where we feel comfortable having families adjust the dose on their own. So I usually will start with 1 capsule a day and then give a range to adjust. And like I mentioned, I have a low threshold for adding in a stimulant. So in the beginning, I might just have it as needed or not really there at all. But, if we're struggling a little bit, I might add in, just for example, like a 15 milligram chocolate chewable square, or, it comes in like at least in the United States, like 8.6 milligram tablets that we can do 2 of. I think that's kind of like a usual one-time daily dose to start with. And then we can also adjust that dose too.
What's the 3350 stand for? What is that all about? Is that the...
It's got to be better than the 3349.
Yeah, the 3349 is terrible. Yeah, that was a bad formulation.
Yeah. So I believe it's the molecular weight, but if I'm wrong, please cut this out.
I like it. All right, yeah, we'll fact check that.
Yes.
Maybe in addition to medication, are there other psychological therapies for kids that are having behavioral issues or withholding? Or it sounds like you mentioned maybe some pelvic floor. What are some of the other non-pharmacological therapies that can sometimes be helpful?
Yeah, so I do think that for some patients, behavioral therapies can be a big part of what ultimately helps them improve. And so in reality, we have a bowel management clinic here that involves a GI psychologist plus a GI provider. And so, that may be as simple as like just tracking stools, implementing some kind of reward system. But yeah, it can also, especially once kids are struggling enough to have stool accidents and withdrawing from school. I mean, there's a lot of other factors that play into their overall presentation. So yes, the involvement of a GI psychologist or a behavioral specialist can play a big role in that. I had mentioned, pelvic floor therapy before, and that's really more for like a more specialized cohort. So those who we've identified pelvic floor dysfunction as kind of their underlying cause. So they have an issue with their outlet, they can't relax. And so if anything, that's even more common in adults. So there's some physiotherapy or biofeedback therapy exercises that can help guide and teach children to be able to push effectively and relax their pelvic floor at the same time. There's some video games that have been created for that. So usually kids kind of get it and they can squeeze and this character goes up or down and relax, that kind of thing. So that helps them to control their pelvic floor. So yeah, there are a lot of different things that have been looked at that are not medications. But yeah, behavioral treatment is a big part of that. And then in certain patients, pelvic floor physiotherapy may be an option.
Well, Peter, thank you so much for talking to us today. I learned so much, and I'm sure our listeners did too. Do you mind helping us wrap up a couple main take-home points that you want our listeners to come away from this episode?
Yeah, sure. So, once again, thank you so much for inviting me. I feel very passionate that even though constipation is common and usually easily managed, I do feel like we need to recognize that it can be devastating to children, especially when fecal incontinence is involved. I feel like it's one of those things where, the hospital is never going to advertise the kid who's soiling their pants. No one wants to talk about this. Parents don't want to talk about it. And it's just it's kind of sad to see, how much it can really change a child's demeanor and then how much happier they are, once you finally take care of it. So I feel like it's important to recognize and kind of take constipation seriously as something that can really impact a child. I think the other, the second thing that I would want to remind people about is to not be afraid of stimulant laxatives. I think that even a little bit in the pediatric GI world, there's some, wariness of using stimulants for too long, that kind of thing. But really, that can be the child responds to even better than our usual stool softeners. For the child with fecal incontinence, sometimes softening the stools more just makes the accidents worse. They may need a stimulant to help push that stool out. So I would say to not be afraid of stimulant laxatives. And if we're still struggling, if the child's not responding, give your friendly neighborhood pediatric GI doctor a call.
Love it. Embracing the Senna.
Yes.
Is there anything that you would like to plug? I know you're a part of a lot of cool teaching projects. What are some things that we can send our listeners to check out?
Yeah, sure. So as alluded to before, I do host a podcast called Bowel Sounds, the Pediatric GI podcast.
Amazing name.
Thank you. We almost went with Tummy Time, which
also good.
Thankfully was taken because no, it's way worse. But so Bowel Sounds, it's like our NAS Begins, our Pediatric GI Society podcast. So if you are interested in hearing more about a variety of different GI topics and GI adjacent topics, check it out. And one other thing I'll just plug too is our society has a toolbox. It's like a mobile-friendly website that used to be an app. It's toolbox.naspghan.org. Basically, it's like a little reference that has a lot of resources for really a lot of these guidelines I mentioned are there for GI fellows or even, ED, whoever. If there's a foreign body, there's algorithms. If there's a GI bleed, there's algorithms to use. Pat Reeves is a young GI doc who helped put a lot of that together. And so I would check out that toolbox. I think that can help a lot, especially if you're on your GI rotation or if there's a GI issue that comes up.
Wow, this website's amazing. I'm glancing through it right now. I'm going to have to go through it.
This is a cool resource.
Honestly, I check it when I'm on call too. Like if I get called from an ED, there's like a nail this size, this age. That's what I'm pulling up while I'm talking to them. So
nice. This is wonderful. This has been a great, I think, overview of diagnosis, treatment, and some very cool pearls and great resources for everyone. So we're very appreciative. Thank you for sharing your time, your expertise. We really appreciate having you on. Thank you for joining us, Peter.
No, once again, thank you for the invite, and I appreciate so much what you guys do for our medical community. So keep up the good work.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our Knowledge Food Formula Feed newsletter at our website, thecribsiders.com.
We're committed to providing you with high-value practice change and knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or your favorite podcast player. You can also email us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Dr. Brian Ward, who is also the runner of the weekly Knowledge Food Formula Feeds newsletter. A big thank you also to our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Dr. Brian Ward.
There it is.
And this has been Chris the Chu Man Chu. I'll pod you guys later.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.